Welcome to this Tachycardia Management OSCE video for AUT Postgraduate Critical Care Paramedicine. In this video I'm going to discuss the tachycardic rhythms, the pharmacology used in the management of the tachycardias, the physiology of the Valsalva maneuver, cardioversion and sedation, and I'll compare some aspects of current international best practice as per the American Heart Association with current New Zealand intensive care paramedic clinical procedures and guidelines. Initial management of the tachycardic patient is the same regardless of the underlying rhythm. First we need to identify that the patient has an accelerated ventricular rate. Then we want to attach the defibrillator pads, obtain a 12-lead ECG to allow for rhythm and ischemia or infarct identification. We want to gain IV access in a large vessel, such as a cubital fossa. Prepare to treat cardiac arrest, particularly if the patient's significantly compromised. And if the patient has clinically significant signs of shock, we want to administer oxygen as per CPG 1.15, I think it is. The cardiogenic shock protocol may only be used if arrhythmia is not the primary cause for the patient's condition or presentation. For example, atrial fibrillation secondary to infection or volume depletion. In this setting, after obtaining a 12-lead ECG and gaining IV access, 250 to 500 ml boluses of sodium chloride may be administered up to a maximum of 1 litre, provided the patient has no respiratory crepitations or shortness of breath. Adrenaline administration should of course be withheld due to the beta agonizing effects of adrenaline, ultimately worsening the patient's condition and putting them at increased risk for cardiac arrest. Identification of the underlying rhythm is key to providing the appropriate management for each patient. This requires some basic cardiology knowledge and rhythm interpretation skill that is beyond the scope of this video. A detailed discussion surrounding these is outlined in Walraven's Basic Arrhythmias and Garcia's The Art of 12-Lead ECG Interpretation. Basic principles include just noting the rate, regularity, the width and morphology of the QRS complexes, the atrial activity, and any precordial concordance. Other electrophysiological signs that can be useful but are observed less commonly include delta waves, fusion beats, capture beats, and pacing spikes. Slowing down the ECG printer speed can be useful in this rhythm interpretation as it prolongs the x-axis of the ECG, allowing for easier complex viewing and rhythm interpretation. Arrhythmia needs to be considered as a potential cause in patients with any unexplained hemodynamic insufficiency, syncope, falls, chest discomfort, or respiratory complaints. Ventricular tachycardia is a wide complex rhythm with concordance throughout the precordial leads, varied P waves, no fusion, or capture beats. It can be non-sustained and self-limiting within 30 seconds, or sustained, lasting a prolonged period of time. It can be monomorphic, which is most commonly associated with myocardial infarction, or polymorphic, with changing wave amplitude and axis. Ventricular tachycardia can present both with and without a pulse, and is the most likely rhythm to deteriorate into cardiac arrest. The patient with stable VT who doesn't have significant signs of shock, hypotension, loss of consciousness, acute heart failure, or chest pain can be considered to be not severely compromised. These patients are treated with amiodarone, procainamide, or sotalol. If the VT is monomorphic and regular, then adenosine can also be considered with minimal risk, though this isn't described within the New Zealand CPGs. Adenosine mustn't be given to patients with polymorphic VT due to the risk that the rhythm will degenerate or deteriorate into VF. If the rhythm fails to revert, then synchronized cardioversion should be considered. In New Zealand, amiodarone is the only drug used in the management for ventricular tachycardias, though the American Heart Association describes sotalol and procainamide for this use. Amiodarone is an antiarrhythmic, a class 3 antiarrhythmic, blocking potassium and sodium channels, prolonging phase 3 of the cardiac action potential, prolonging the relative refractory period, and stabilizing conduction through nodal tissues. It has a class 2B level of evidence from the American Heart Association and is administered as a 300 milligram in 100 ml IV infusion over 30 minutes. In comparison, procainamide is a class 1A antiarrhythmic drug with a class 2A level of evidence that works by blocking sodium channels, slowing dromatropy and prolonging the effective refractory period. A 2017 study in the European Heart Journal found procainamide to be associated with fewer adverse effects and a greater rate of tachycardia termination. Sotalol has both beta-blocking and class 3 antiarrhythmic effects and a class 2B level of evidence from the American Heart Association. Like amiodarone, sotalol blocks potassium channels, prolonging the relative refractory period, but it's unique in that it also has this beta-blocking action, acting as a beta-1,2 adrenergic receptor antagonist. Synchronized cardioversion is used in the treatment of tachycardias as these timed shocks avoid the relative refractory period and prevent the rhythm from degenerating into ventricular fibrillation. If the defibrillator cannot synchronize, then the American Heart Association recommends that you provide high energy unsynchronized shocks. Section 3.10 of the CPGs outlines the cardioversion checklist that must be followed during cardioversion. If the patient can obey commands, then ketamine needs to be administered in a 0.5 milligram per kilogram dose to achieve dissociation. Ketamine is the drug of choice as it is it's respiratory and airway protective while producing excellent and adequate analgesia, amnesia, and dissociation. I'm going to run through that checklist now. Number 1. Place pads in either the apex sternum or anterior-posterior position in addition to ECG electrodes. I've already mentioned taking an ECG. Ensure the defibrillator is in manual mode. Select a lead with a visible R wave and ensure artifact is minimized. Select synchronized mode. Confirm that there is a detection symbol above every QRS and ensure that the patient has received enough analgesia or ketamine for dissociation if required. Select the joules, charge the defibrillator and ensure that everyone is clear. Press and hold the shock button until the shock is delivered. Determine the rhythm and the level of cardiovascular compromise, and if the patient requires a second cardioversion, then you need to make sure that the monitor or the defibrillator is still in synchronized mode. Supraventricular tachycardia is an umbrella term that broadly describes any tachycardia that originates from above the ventricles. The four most common rhythms are atrial fibrillation, paroxysmal SVT, atrial flutter, and Wolff-Parkinson-White syndrome. As SVTs can occur as a result of non-cardiac factors such as massive caffeine intake, stress, or sepsis, for example, treatment of the underlying cause takes priority. This is because incorrect or inappropriate pharmacological management or indeed electrical management of a arrhythmia can have serious consequences for the patient. If the patient is not severely compromised, then up to 2 Valsalva maneuvers should be attempted. By blowing forcefully into a syringe, intrathoracic pressure is increased and venous return, stroke volume and cardiac output are decreased, decreasing blood pressure. When the intrathoracic pressure is released, a sudden increase in venous return, stroke volume and cardiac output causes a homeostatic reflexive decrease in chronotropy. This reflex is controlled by the intra-aortic baroreceptors. The modified Valsalva manoeuvre is used currently within New Zealand as it's been shown to elicit a greater likelihood of tachycardia termination. In this method, the patient is lay down with legs raised after they release the pressure to further increase intra-aortic pressures. Adenosine is a drug of choice for New Zealand intensive care paramedics if Valsalva manoeuvres aren't successful in terminating the rhythm in patients who aren't severely compromised. Given in 6 mg doses or 12 mg doses if 6 mg isn't successful in reverting the rhythm, followed by a 20 ml flush. Adenosine slows conduction through the AV node and can interrupt reentrant pathways. It is for this reason that adenosine is not used in atrial fibrillation or atrial flutter. If given in these two or for these two rhythms, adenosine may increase the ventricular rate and worsen the patient's condition, potentially precipitating ventricular fibrillation. Adenosine must be administered rapidly, as its half-life is very short. With metabolism beginning within a few seconds of administration. A three-way tap can be used to increase the efficiency of drug administration and flush efficiency, but these aren't currently available in New Zealand ambulance manifests. Interestingly, the American Heart Association guidelines describe asthma as a contraindication for adenosine administration, but in the New Zealand CPGs, asthma is only listed as a caution. Though not currently administered in New Zealand, the American Heart Association recommends calcium channel or beta blocker administration for the termination of SVT if vagal maneuvers or adenosine administration has failed to have effect. I've previously administered a patient's prescribed oral beta blocker with good effect after a phone consultation with a medical director when I was transporting a patient with SVT a prolonged distance of about 3 hours. That it was successful in terminating the rhythm. Neither beta blockers or calcium channel blockers are currently carried by New Zealand intensive care paramedics, but I suppose this is a thought process that we should be having. If pharmacological treatment and vagal maneuvers fail, or if the patient is severely compromised, then synchronized cardioversion is the treatment of choice. This is performed exactly as I've previously described. Atrial fibrillation is irregularly irregular with no obvious discernible P waves. The QRS complexes and T waves are visible, but T waves may appear to have strange morphology due to the continual electrical activity within the quivering atria. Atrial flutter is a regular rhythm with an increased P wave to QRS complex ratio. In this rhythm, the P waves have a jagged or sawtooth appearance. These waves may not be immediately obvious, depending on the heart rate. Turning the ECG upside down may help with identification of these flutter waves. QRS complexes appear as normal, T waves may be buried. Atrial fibrillation and atrial flutter are rhythms of upper cardiac dysfunction, where the electrical activity in the atria is either disorganized and irregular, as in atrial fibrillation, with multiple controlling foci, or it's organized with a regular rate and P wave or sawtooth morphology, as in atrial flutter. It's rare for these rhythms to cause significant levels of cardiovascular compromise unless there's an underlying cause, such as in sepsis or volume depletion. The treatment for the rhythms is the same, either pharmacologically with amiodarone or electrically with synchronized cardioversion. Because of the electrophysiology of atrial flutter, the rates of this rhythm are typically set at around 300, 150 or 100 beats per minute, depending on the proportion of blocked atrial contractions. The American Heart Association recommends beta blocker or calcium channel blocker administration as the first line of pharmacological management for these rhythms with a class 2A level of evidence. Beta blockers are used in arrhythmia and hypertension management and in secondary MI prevention. They are competitive beta 1, 2 and 3 adrenergic receptor antagonists, but are used in the treatment of tachycardias for the beta 1 effects on chronotropy, inotropy and dromotropy. A reduction in renin release interrupts sympathetic nervous system activity through the action of the renin-angiotensin-aldosterone system. Interestingly, these drugs are being researched for their role in anxiety management, and as it is commonplace for people to take non-prescribed beta-blocking drugs before stress or anxiety-inducing events. Calcium channel blockers are used for hypertension, coronary artery disease, arrhythmia, and angina management. The mechanism through which these act is through a decrease, again, in cardiac inotropy, dromotropy, and chronotropy, mediated by interrupting normal cell conduction, prolonging the cardiac action potential in the cardiac myocytes through alterations in calcium ion movement across cell membranes. Another tachycardic rhythm we see, but less common than, say, SVT or atrial fibrillation, is the ventricular paced rhythm. These rhythms aren't treated pharmacologically due to their mechanical nature, but can be terminated by returning the pacemaker to its factory settings with the use of a magnet held just over the pacemaker site over the skin. This process is done in hospital under the guidance of a cardiac pacemaker physiologist, with close patient monitoring and staff nearby prepared to provide resuscitation. There are many examples of tachycardic rhythms that should not be managed using these algorithms. One of the presentations that we see not infrequently within the ambulance setting is cyclic antidepressant toxicity or poisoning. Cyclic antidepressants are highly cardiotoxic in large doses and are the family of drugs that contribute to one of the most common presentations of overdose in emergency departments. The mechanism of the resulting sinus tachycardia is by the inhibition and blocking of myocardial sodium channels and sodium ion current. This prolongs the PR, QRS and QT intervals and depresses myocardial contractility, which results in hypotension and arrhythmia. Management of the tachycardia is by administration of high-dose sodium ions. Within New Zealand we would use either sodium chloride or sodium bicarbonate. Management with adenosine, as per the SVT algorithm, could precipitate a prolonged and deadly sinus pause. Though not practiced in New Zealand, I want to mention overdrive pacing, which is a method of reducing the tachycardia by setting up the monitor or defibrillator in pacing mode at the rate of the tachycardia and dialing the rate down to a level that is normally perfusing. This method isn't currently supported by the American Heart Association guidelines, which do make mention of the technique, but don't provide any recommendation or level of evidence. Overdrive pacing can be dangerous because it can result in the termination of a ventricular tachycardia into a ventricular fibrillation. It has no use in the management of atrial fibrillation, ventricular fibrillation, or sinus tachycardia. It does have a few advantages, however. It doesn't require dissociation with ketamine, as cardioversion does, and it reduces obviously the side effects and myocardial depressive effects of a DC shock.